Welcome. We'll go ahead and start. Thank you all so much for coming today to the North America workshop of the GANSID Congress 2023. I don't know about you guys, but I've been really energized by the talks that have been going on since this morning. I've learned so much, and I can't wait to continue to do the work. And that's what we're here to do today, to kind of discuss as a North America team, where do we see the high priorities of doing the work? Well, I'm Dr. Titilope Fasipe. I'm one of the pediatric hematologists who take care of children with sickle cell in the Houston area, Houston, Texas area. And I am honored to be here today. I also am a person living with sickle cell disease. And so this event means so much to me on many levels. And I'll let my other co-presenters introduce themselves, and we'll get started soon.
Hi, my name is Dr. Carolyn Rowley, and I am the Executive Director and Founder at Cayenne Wellness Center located in California, where we take care of persons with sickle cell disease across the state with the help of our compassionate community health workers. We do support groups, we do advocacy, and I think we're best known in the sickle cell space for the education that we provide, be it our annual Sickle Cell Education Summit, our annual Hispanic Heritage Sickle Cell Seminar, our nursing seminar, mini seminars, etc. And I'm really happy and honored to be here as well. Thank you.
And I'm Dr. Valentino. I am a hematologist. I practiced in Chicago for 30 years, taking care of children, adolescents, and adults with classical hematological disorders, including bleeding disorders, sickle cell disease, thalassemia, anemias, etc. I retired from academic medicine in 2013 and spent 7 years in industry doing drug development, primarily around gene therapy. And then in 2020, I joined, at the time, the National Hemophilia Foundation, now the National Bleeding Disorders Foundation, as its president and CEO. So as a classical hematologist, as an advocate, as well as an ally for people living with inherited bleeding and blood disorders, I'm happy to be here and happy to be part of this Congress and, more importantly, this movement. So thank you.
And Dr. Rowley, would you like to get started? And if you can also go through our housekeeping for our attendees as well.
I would love to. So this is just a reminder. First of all, thank you all for joining us, number one. Number two, this is just a reminder that if you have a question, that you can put it in the chat, I believe, and you can also put it in the Q&A. You can also raise your hand, but we do ask that when you come in, if you're not already muted, that you actually mute yourself so that we can have the presentations heard and enjoyed by everyone. And so that's what we ask. So we're going to get started. So thank you. My talk is Guess Who's in the Waiting Room? Educating healthcare providers, especially in the emergency room, on quality care for sickle cell disease in North America. My name again is Dr. Carolyn Rowley here at Cayenne Wellness Center. And again, I am pleased to have been invited to participate in this year's Congress. Emancipation 228. This was written by a warrior, Diamond Ray Edmondson. Here we go. Emancipation 228. I'm awake. It's late. Try to move, but I can't. The pain is, where isn't it? A crisis is evident. Head pounding, back aching, pain as it goes down the drain to the leaves I raked. My life's at stake. So now there's a choice to make. Do I lay awake as I lay and wait for the effects of the drugs I take? Or do I travel to that God-forsaken place where they perform CPR, done in an ER, where they treat us like we are drug addicts? Like it's my fault I built up the tolerance for the following. Hold on, let me get the list. There is oxycodone, Vicodin, Dilaudid, morphine, Tylenol with codeine, and other antibiotics. Crazy, right? Kind of idiotic, almost psychotic. If I wanted to use and abuse a drug, I would have come here and gotten it. Crazy, right? Transition to that baby life is like moving from day to night with no lights in sight. You're blind. Meanwhile, I'm just trying to find the strength to get up because the pain won't let up. Hard to put in words until you get to the point where eyebrows hurt and you have to hold your face in place. The unmeasurable straight that takes not to break. I succumb to the pain. I declare an emergency and I head to that room where I will surely have to wait. I get there at 1:08, am greeted by Kate, who hands me a clipboard and said, "Here, fill this out, then sign and date." Kate obviously doesn't see my face filled with tears from a mind that is filled with fear that I might die tonight, right here, right now. I'm filled with frustration. I'm losing my patience and gaining temptation to bang her head against the desk and make her face readjust, but I just slam it down the clipboard with full force out of anger. And I tell Kate, I've been here before. Don't treat me like a stranger. I'm in danger. Look me in my yellow eyes. My counts are low. My pain is high. Yes, my calm demeanor may come as a bit of a surprise, but I ask you to realize the severity of the situation. Now, I'm not trying to play mind games, but I really have a migraine and I can hardly stand up straight because of the way my back aches. Now, I filled out your form, signed and dated, and now I ask you, I beg you, please don't make me wait. She sends me to the back. They take my height and weight, insert the needle, make sure I hydrate, 1 shot. In goes the needle, but it won't take, 2 shots. My arm bent, but it won't break, 3 shots. I can't concentrate. I contemplate how much more can I take as the evil needles penetrate my skin and the pain within. They try again, success. And I think, amen, because I'm exhausted. And I thank God for patience because I nearly lost it in a night filled with blues and frustration. And I am reminded, steady, I'm delivered that my loves, I'm transporting it upstairs where I meet Nurse Betty, who informs me that my room is ready. It's now 3:03, and I have never been so happy to see Bed B. I walk in and greet my roommate, who surprisingly is awake, and accept the fate of room 228. Again, that is written by Diamond Ray Edmondson, who is no longer with us, and Sickle Cell Warrior. I'm going to start briefly just talking about the politics of race and health and move our talk towards the emergency care. So before 1900, part sickle cell disease was invisible and ignored. I mean, there were some different types of writings that shared like what Africanus Horton had actually written about something that was going on that would make these people bent over and die young. But it was pretty much invisible and ignored. So right around 1910, as many of us are aware, Walter Clement Noel, our person from Grenada, and James B. Herrick, there was a paper written in 1910 about Walter Clement Noel. And then right around 1949, Linus Pauling, who was awarded 3 Nobel Prize awards in 1949, he noted sickle cell disease as a molecular disease. But this is where sickle cell has a turning point, and it has to do with the politics right around the 60s and 70s. So it was the Black Panther Party that put sickle cell disease on the map, at least here in North America. So what was happening is that Black Panther Party had their 10-point plan. It was wonderful, their platform. And one of the things that they actually had was sickle cell disease. So at one time, they had actually done about 16, between 15 and 16,000 trait testing. That was wonderful, right? At the same time, Richard Nixon was running for president, and his numbers were low, and he didn't have the Black vote. Also, at the same time, the Mike Douglas show. You may not remember who the Mike Douglas show was about. It was a talk show, very popular. And at that time, they had Yoko Ono and John Lennon, who were the host. And on that show, they had Bobby Seale and other Black Panther Party members. And they had national TV coverage about speaking about sickle cell disease. So Nixon wanted to find out, again, how to gain that vote. And so he took what the Black Panther Party had already figured out, how they were going to have newborn screening across the state. Well, with Nixon taking on sickle cell disease, it's kind of bittersweet because as a result, there were actually national funds that actually poured in as a result of Nixon putting that as his platform. And then there goes the progress since then. And then regarding newborn screening, the first time it took place in 1973 or 5 in New York. Across the US by 2006, everyone had newborn screening, all states. And in California, that was in 1990. And then moving on in 21st century, disease as a moneymaker. So for a while we had hydroxyurea, which it worked. It worked. They actually ended the study early because of the effects of hydroxyurea, so it was very effective. But it took decades before we had disease-modifying therapies like Endari, Adecvio, and Oxbryta, 2017 and 2019, respectively. So that's just giving you a little bit of the history of sickle cell disease, at least here in the US. Then I want to move to what's called the pain game. I'm not going to read it given the time, so I'm sharing with you how you can find this article. It was in Discover magazine, written by Dr. Rosenthal in 1993. And what I wanted to share with you is she wrote on what it was like when a person came in with sickle cell disease and that talk that that was taking place behind the glass. I'm only going to read you an excerpt. I really would like for you all to look that up. And it's pretty compelling in terms of just the attitude that took place then and now. Guess who's in the waiting room? The charge nurse sings out in a high-pitched voice as she walks into the emergency department. Without waiting for our guesses, she answers herself, Lavinia. A chorus of doctors and nurses' voices erupts from the workstation. Her again? Ugh, what a wimp. But I just saw her here 2 weeks ago. Oh no, not Lavinia. I'll admit, this is Dr. Rosenthal. This is unbecoming conduct for health professionals talking about a patient, particularly one with a serious chronic disease. And if you were to meet the person whose presence provoked this outburst, you'd be even more appalled. Lavinia Johnson is a perfectly pleasant, well-mannered, and well-dressed 29-year-old Black woman who works as a computer programmer and is a voracious reader of science fiction in her spare time. So what I am going to just share to summarize is that they continue this feeling. Dr. Rosenthal asked Lavinia, how is she feeling? What does she normally take? And she gives that to her, which is 125 milligrams of Demerol and 50 milligrams of Vistaril. And then when Dr. Rosenthal goes to write the order, they then share with her, oh my goodness, you've gotten used, you're a sucker, etc. So to where she begins to doubt her belief, but she does give it to Lavinia in the end. And so you can continue to read on. I'm going to fast forward to the end where she speaks about going to the end. So 7 hours after she First walked into the door, me and shuffled towards the nurse's station. Watch her. She's one of those patients who have been around hospitals long enough to know just how to keep them. But as she pokes her head into the workstation, she says, I think I want more shot, and then I'll be ready. Does she still have pain? Should I give her another shot? Does she just want another injection as an insurance policy to make sure the pain won't return when she gets home? Wouldn't I want one last shot if I were in her situation? I have no reason to believe that Lavinia is addicted. She's working on stable doses of drugs. And anyway, I decided for myself that I would rather give narcotics to someone in the emergency room who's not really in physical pain than withhold drugs from someone who's truly hurting. So I write the order for another injection. An hour later, Lavinia is at the door, dressed and ready to go. She thanks me for her care. I wish her good luck in her quest for a job promotion. I like her. I believe she was in pain. I know she has a bad disease, and yet I make sure to update her card in the battered green box. Demerol 125, Visceral 50 times 3. No infection. Discharged with 25 Percocets to go. Probable bleed disease. This is what we want. And that Dr. Rosenthal believed Lavinia, despite the rumblings of her colleagues and the other providers in the room. So now we'll talk about how education and awareness is taking place in North America. So I had the pleasure, in preparing for this talk, of meeting with Annie out of Ohio Sickle Cell and Health Association in terms of what they're doing. She's located in Columbus, Ohio, with Andrea Matthews at the Children's Sickle Cell Foundation in Pittsburgh, with, of course, myself, and we'll talk about what we're doing, and as well as receiving information from the Sickle Cell Awareness Group of Ontario. So briefly, in the United States, we have approximately 100,000 persons living with sickle cell disease. 2 million Americans are diagnosed with sickle cell trait, and approximately 1 out of every 500 African-American births, people are born with sickle cell disease, and 1 out of every 36,000 Hispanic American births. And as I mentioned earlier, newborn screening took place in the early 70s, first with New York, and then 2006 by all states. In the United States, at least here in California, we have roughly about 7,000 persons with sickle cell disease, and about 2,000 in Ohio, and I was not able to get that information from Andrea. As we know, patients unfortunately are stigmatized in the emergency department, frequently labeled as drug seeking, and receive delayed and or denied access to pain medications when presenting for medical treatment. This leads to a high mortality rate because of the challenges in receiving adequate care. In California, at least in the US, California has the worst by 15 years. So we're going to start briefly with what's going on in Ohio. We'll look at Philadelphia, what we're doing, and then we'll actually share with you some recommendations. So I had the pleasure again of speaking with Annie Womack, who's the executive director at the Ohio Sickle Cell and Health Association. And so this is what she shared with me that they're doing, and it's pretty neat. So in terms of how they actually educate and make aware the persons in their state, they actually recruit doctors and nurses to be part of their team. They actually speak with the nurses at the hospital. One way of doing that is they have an MOU with the Black Nursing Association. And so they have the nurses, they share with the nurses what they need, what kind of tone to be set as they do the rounds on the floors. They also reach out to medical directors, and they're educating the hematologists. One thing that I was impressed with is that they also speak on a regular basis with the medical board, the nursing board, and the pharmaceutical board, in addition to the state medical disability office. I think that's wonderful for that to actually be occurring so that these entities are aware of sickle cell disease and the work that the CBO is actually doing. With respect to Pittsburgh, Pennsylvania, I actually had the pleasure of speaking with Andrea Matthews. She's the founder, and Michael Matthews, her husband, is the executive director. And this is what they're actually doing in their state. And I thought this was wonderful as well. So they have relationships. There are 13 different, at least in Pittsburgh, federally qualified health centers. So what they do is they actually do presentations at those centers to raise awareness. There are additional 5 CBOs in their areas. They work closely. And I'm impressed because they've actually formed these different subgroups. One of them is the ER Accountability Health Committee. And so their job is to improve the experience of persons with sickle cell disease in the ER department. And they also have a survey to be able to do that. I thought that was pretty impressive. Also, they have what's called their Living Well with Sickle Cell Summit every year. They also have an Advocacy Day. And what they do is if they haven't seen or if a person has been out of their database for a while, they actually attempt to reach unaffiliated patients who have not been seen by a provider for at least a year or more. And they have a 1-800 number or 855 number, and then that person will be connected to a CHW, community health worker. But this is the one that I'm most impressed with. It's interesting because I thought I was the only one. For about 5 years now, I have always been thinking for our persons with sickle cell disease who unfortunately they're incarcerated, what kind of care do they receive? And I've been thinking about that and expressing my concerns with the CDC and the SCDC, sickle cell data collection. Well, they're doing it here in Pittsburgh. And one of their subgroups is called the Care of Incarcerated Person Initiative. So UNPC, they have a model as to how they are addressing this. So I look forward to reaching back out to Andrea Matthews to find out more about doing this initiative here in California. All righty. And then with respect to Cayenne Wellness Center here in California, I mentioned earlier, so we're known in the space for the education that we do. So we have an annual summit. We have an Ask the Expert series monthly. We have these little mini seminars that really dig deep into mental health or sleep or the brain, etc. We have annual Hispanic Heritage, Arthur's Corner, a transition program, and we also do provider in-service training. These are the ways that we educate persons, healthcare providers, warriors and their families in the community. With respect to awareness, we do health fairs partnered with our medical centers and churches. And here in California, we have over 2,000 federally qualified health centers. So what we're doing is we've put out a huge mailing to go out to all of these federally qualified health centers to introduce us. And then after those mailings are completed, which will be by March, we'll then circle back and start doing what Pittsburgh is doing, inviting ourselves to see if they would like to have training. And then we also do advocacy, both at point of care, and we partner with Sickle, SCDAA, and SC3, who do it legislatively. Some of our initiatives is we have a mental health initiative since April of last year. And so we have free mental health to those persons diagnosed and living with sickle cell disease and their family here in California. This year, we also have a sickle cell trait awareness campaign. And so again, we're putting out mailings to schools, colleges, and the federally qualified health centers. And we use social media as well. Coming soon, we'll be doing March on Hospitals and looking at more career planning. Let's talk about Canada, and then we'll get into some of the recommendations. So in Canada, they have about 6,500 persons living with sickle cell disease across Canada, and specifically in Ontario, roughly about 3,500. Unfortunately, Canadians with sickle cell disease continue to die from largely preventable complications of sickle cell disease. And just like here in the US, patients continue to be stigmatized in the emergency department, frequently labeled as drug seeking and receiving delayed and denied access to pain medications. I did mention that in terms of the mortality rate, I did mention that it's worse in California by 15 years. In Canada, they have a life expectancy that's significantly reduced by about 25 to 30 years, wow, compared to other Canadians without sickle cell disease. So unfortunately, they have a quality of life that's also lower than other Canadians. Depending upon the hospital of admission across the country, they do receive suboptimal care and treatment, resulting in preventable complications and possibly premature death. And they do not have access to comprehensive care, including life-saving treatments, drugs, or knowledgeable care providers. Specifically in terms of what the Sickle Cell Awareness Group is doing, again, I'm pretty impressed. They have this e-course for providers open to clinicians treating persons with sickle cell disease. They've also conducted many research studies, including the number of those affected and identified in the hospitals that are providing suboptimal care. And in June 19th, rather, they were able to get World Sickle Cell Day passed as law to increase awareness of the disease among the policymakers. They also receive funding. This is also a great feat. They receive funding for 7 hemoglobinopathy centers of excellence, and they're also advocating for 3 more comprehensive centers as well, bringing it to 10 centers of excellence. That's pretty impressive. And of course, unfortunately, many sickle cell disease patients are accessing care during severe episodes of illness and using the emergency or urgent care. And that happens here as well in the US. So there is a need to improve staffing resources in these centers to truly make the centers comprehensive. All right. So we're going to talk about some of the standards of care, and I'm going to go through quickly here. So right now, there's the NHLBI guidelines, the ASH guidelines, and then EDSC3. I'll quickly go through those and then give you recommendations. So the evolutions of standards of care. So NIH, their first edition of their standards came out in 1984, and their last edition was in 2002. NHLBI, their standards came out in 2014. And then ASH, their standards came out in 2019, and they continue that all the way through 2021, looking at cardiopulmonary kidney, cerebral vascular disease, acute and chronic pain, transfusion, and transplant. So with NIH, they published their book, they published a concise book with chapters, and it was not a consensus recommendation, mainly expert opinions. NHLBI, they actually, and it currently exists, they have a downloadable book. Evidence were available to support standards, and many were by consensus. With ASH, theirs is published in Blood Advances as an open access journal. And the standards have been available over that period of time for 3 years. And it's supported by evidence in the literature, relatively few strong recommendations. And then now there's EDSC3, which you may or may not be aware of, which stands for the Emergency Department Sickle Cell Care Coalition. And they're working to improve emergency department care of individuals with sickle cell disease. And so briefly here, what they did is they came together. There was a summit on emergency department care for sickle cell disease, and that was held in 2015. And from that led to a formation of a national coalition, which is now known as EDSC3. And so currently they receive staff support from the American College of Emergency Physician, or ACEP. EDSC3 will continue to develop and disseminate educational offerings on sickle cell disease to all providers working in the ED. And they're also committed to this work until all, and I like that, until all ED clinicians are proficient in delivering guideline-based care for individuals living with sickle cell disease. And if you want to take a screenshot, let me move it down, you can look at, I have there we go. I have the website here if you want to take a screenshot to get more information. And finally, I'm going to go with the recommendations. So I highly recommend, if you haven't already, that you read Jeffrey Glasper's article on how to improve emergency department-based care. It's an excellent read. I require that for all of our staff members onboarding. We always speak about that at our nursing seminar, our provider in-service training, even educating the medical students here. Second, we recommend that there's always ongoing education to ED staff. Third, ED and hospitals, we believe, should form partnerships with CBOs in their area. 4, we invite sickle cell warriors and caregivers to serve on the advisory board at the hospital. You should have a seat at the table. 5, the pain is real. To anyone that is listening, the pain is real. Believe the sickle cell warrior and the rating of their pain. 6, look beyond the pain. Sickle cell warriors are human beings. Other things might be happening. So we always recommend to dig deeper, do a differential diagnosis. Something else might be happening. 7, if warriors report that the pain is different than their regular vaso-occlusive crisis, keep them for observation. And again, do a differential diagnosis. Something else might be happening. 8, again, the pain is real. Warriors know what meds work for them. It saves time. Do it, just like Dr. Rosenthal did. 9, encourage warriors to not come to the emergency department alone. I always share this with everyone. Attempt to try to come to the emergency department with someone. And 10, sickle cell warriors are teachers, architects, wife, a husband, sister, brother. They are human, and we ask that you remove your bias. We don't have time for a story of Natasha, but I will end with asking you all to take the sickle cell pledge. And so I'm going to put this on the screen here for you to scan. And then I ask that we all read it together, and then I'll turn it over to my colleagues. Give you a second to do that. Okay. All righty. Cayenne Wellness Center Sickle Cell Pledge. If you can read with me, I appreciate it. It starts with you. It is unacceptable for the medical community to tolerate this racist mistreatment of patients living with sickle cell disease in our emergency departments and hospitals. Our hospitals and clinics must be safe spaces for patients with sickle cell disease. It starts with you. All healthcare providers must be open-minded and self-aware as they care for patients with sickle cell disease, recognizing their own implicit biases and making a conscious effort to treat patients equitably, regardless of race. It starts with you. United action against racism's impact on the health of patients with sickle cell disease is long overdue. It starts with you. Change begins with the conversation, but words are not sufficient. We must take action to improve the care of patients with sickle cell disease. Now, everyone, let's take the pledge together, and I'm hoping that you'll read this along with me. Persons diagnosed with sickle cell disease are born into pain. Persons diagnosed with sickle cell disease are human beings. They're someone's wife, husband, daughter, son, mother, father. I will stop calling and referring to patients as sicklers and frequent flyers and correct others when they do it. When I see something or hear something, I will say something. I now know that the majority of patients diagnosed with sickle cell disease are not drug addicts, nor are they feigning their pain. Only 1% of the population may have issues with addiction. Persons diagnosed with sickle cell disease know what works for them to manage their pain. Knowing this does not make them suspect for addiction. When the patient states that the pain they experience is different, I will assist in making the physician aware to run more tests and keep them for observation. This action can save their life. I will assist in getting persons with sickle cell disease assessed and triaged rapidly, assigned high priority for evaluation, and receive their first analgesic within 60 minutes of arrival to the ED. I pledge to be a nurse, physician, caregiver, advocate for person diagnosed with sickle cell disease. And everyone, I thank you very much for your time. This is how you can actually reach me. This is my email address. As well, this is our website. Thank you.
That was excellent, Dr. Rowley. We will be taking questions in our discussion section, but such powerful words and all those perspectives. And I can't wait till we get to interact with the attendees to discuss your points further.
Thank
and
you.
Dr. Valentino, why don't you go ahead?
Okay. So are you able to see my slides?
Yes.
Okay. So good morning, good afternoon, good evening. Thank you for the opportunity to present here today. I'm going to take you on a little bit of a journey where we've been going at the National Bleeding Disorders Foundation for the last 4 years, and taking you from patient to lived experience expert. So I have nothing to disclose, and what I'm going to present here is my own thoughts and presentation, and not necessarily reflective of the National Bleeding Disorders Foundation or its board of directors. The mission of the National Bleeding Disorders Foundation is on this slide. And one of the things that I want to point out here is that the goal of the foundation is to address inheritable blood disorders through education, advocacy, but most importantly through research, with a bottom line goal of enabling people and families to thrive. So the vision is a world without inherited blood disorders. And it's very important because this focuses on a cure for each of the blood disorders that we all care about dearly. So I'm going to ask the question, who is a lived experience expert or an LEE? So we heard about Doctors Clement and Herrick, and I was privileged to practice at Rush University Medical Center in Chicago, where there was a conference room, the James B. Herrick Conference Room, because Dr. Herrick practiced in Chicago at Chicago Presbyterian Hospital in the 1920s through 1950s, where he encountered Dr. Clement Noel. So Dr. Noel is a lived experience expert. He is a man who lived with sickle cell disease, and by virtue of his lived experience was an expert. So lived experience experts are important in the ecosystem of conducting research, and as we heard in the previous presentation, can provide tremendous insights into the entire care process. So lived experience experts are critical to this entire process. So we've been engaged in a research enterprise in inherited bleeding disorders. So what I'd like to share with you is the learnings that we've had through this process and how it might be applicable to other blood disorders, including sickle cell disease, thalassemia, and others as well. So lived experience experts, the definition is given here. And this definition was actually created by a working group of lived experience experts. So these are individuals, their caregivers, and family members that are directly impacted by inheritable bleeding disorders. Their diverse and personal knowledge gives them the unique ability to translate lived experiences into meaningful system change. Based on this important perspective, lived experience experts should be able to influence and/or drive bleeding disorders research. They should reflect a diversity as vast as those affected by them. So we have engaged our community of people living with inherited bleeding disorders with this perspective in mind. So the research department at the National Bleeding Disorders Foundation has adopted a vision of a world without inheritable blood disorders begins with research. And the goals of our research program are to address gaps in knowledge that can improve the lives of people affected by inheritable bleeding disorders, ensure that the lived experience drives and influences the research process, and promote equity, diversity, and inclusion so that research findings include all. This is incredibly important because implementing research is only as good as it reaching the clinic, and then it has to reach the patient or the person that's living with the disease. And again, I think that what we learned can be translated into other inheritable blood disorders as well. So the first part of our research enterprise began in early 2020 with a community-wide process to identify research priorities that were important to the community. As a hematologist, and then as somebody who worked in industry, I recognize that far too often the key stakeholder in innovation and research has been the shareholder of a for-profit company and not necessarily the patient, who should be the key stakeholder. So our goal in this was to identify what was really important to people living with inherited bleeding disorders. So the product of this community-wide listening was a prioritized community research list of questions that we ranked then on 3 priorities: risk, feasibility, and impact. And it was important to consider the impact of this research on the community and on the individuals, its feasibility, but also the risk. The learnings from this were that the lived experience experts desperately wanted to participate in research. They wanted to be part of the entire process, not just a subject or a participant of the research, but really be a key stakeholder throughout the entire process. We have a community of chapters, and we have 53 community-based organizations or chapters within the bleeding disorders community. And it's important that we also engage our chapters throughout this entire process. So we did community surveys to gather additional inputs. And through the listening that we did with community members, with our chapters, and with lived experience experts, we then empaneled working groups to begin the task of identifying the key research questions. We also obtained a grant from the National Heart, Lung, and Blood Institute to conduct remote participation groups. So our program was initiated during the pandemic, and we thought that it was important to be able to engage people who normally would not participate in these sorts of activities. And the grant that we got from NHLBI specifically focused on bringing parts of the community who were normally not engaged into the process so that we could ensure that we had inclusion of diverse voices. The second phase was building a national research blueprint. So we needed to define what we were going to do. And it was important to integrate the lived experience experts as key members of the research team, grounding them in research process and in health equity, diversity, inclusion, and justice principles. So we created a number of working groups in order to work towards creating a national research blueprint. And you can see here in this little peacock diagram, we have a research and development, infrastructure, and workforce working group. It's important to not only identify what research will be done, but where it will be done and who will do it, not just today, but into the future. And we know that there's a critical need for classical hematology workforce into the future. We also have a working group around community engagement because we thought it was important to continue to engage various stakeholders within the community. And that community includes not only people living with inherited bleeding disorders, and caretakers of those individuals, but also healthcare professionals. But more importantly, we also wanted to engage people who were normally unengaged in the entire process. So we worked hard to engage others. We also want to have involvement of other societies. We heard about the American Society of Hematology, ASH, as well as others that are involved in this community. We also wanted to include stakeholders in industry in our community engagement. The lived experience experts fought and argued that they needed to have their own working group. So that's been a clear and driving force to continue to have the lived experience experts have a place to discuss research priorities and learn more about how they can participate in all aspects of research. We have a policy working group as well that's important in terms of identifying and then breaking down potential systemic barriers towards research and inclusion. And then we have a health equity, diversity, and inclusion work group as well to specifically address issues around implementation of research. Lived experience experts are vital members of each of these working groups, in addition to having their own working group. You can see a timeline in terms of building this national research blueprint. So drafts have been completed of all of the preliminary plans, and all working groups have completed their relevant contributions to the final NRB report and master plan. The steering committee is now taking all of these reports and master plans so that we can create an integrated program that we will roll out through a public comment period. And this public comment period will again be an opportunity for the entire community, as well as those living with inherited bleeding disorders, to comment on the research priorities. So this report will be incredibly important to not only socialize what we hope to be able to accomplish, but continue to refine and get additional feedback. And then we're planning an in-person National Research Blueprint Summit or meeting, January 25 to 27. This will be a hybrid event where not only will we have people in the room, but we also intend on having a virtual component so that we can engage the wide community in ensuring that we have the greatest voices represented throughout the entire process. So the definition of lived experience experts, again, are individuals, their caregivers, and family members that are directly impacted by inheritable bleeding disorders. I think you can take the inheritable bleeding disorders and you can replace that by whatever disease or disorder that you are providing services for. And we can recreate the same sort of program for these other disorders. Their diverse and personal knowledge gives them the unique ability to translate their lived experiences into meaningful system change. And based on this important perspective, lived experience experts should, to the best of their ability, influence and drive the research that's being conducted. They should reflect a diversity as vast as those affected by them. So the step-by-step process is our first phase, as I said, we had a research state of the science that we held in September of 2021. This summit resulted in the publication of 10 articles in expert reviews in hematology that were published as open access so that the wide community could have the ability to read these 10 articles. Not only did we publish this as open access, but then we did series of webinars and presentations to continue to socialize the findings from the research state of the science. The second phase, where we are now, is to develop a national research blueprint, which will result in a comprehensive integrated research plan that integrates the lived experience experts as key members of the research team and grounds the research process in heady principles. And as I said, this will be presented in January 2024 to the wide community. The third phase is really where the hard work begins, where we want to implement the research that we've worked for 4 years to develop. So we'll plan, we'll fundraise, and then we will execute on this research plan, because we believe that only through cooperative research can we really make advances to reach the vision of a world without inheritable blood disorders. So we want to transition people, the patient, from a patient to a research partner. So we think about what we've done in the past. We've had human subjects in research, and many of us have likely participated as a human subject in research. We believe that these individuals have exquisite information and knowledge and constitute subject matter experts. But based on their lived experience, they're truly lived experience experts. And we want to move them from just providing input or consultation and collaboration to true shared leadership, to have a seat at the table, but not only have a seat at the table, but help design the menu and then participate in the meal. And that's what's really important when we think about the entire research ecosystem. We want to have individuals who live with these diseases as our partners in the research enterprise, providing ongoing input. So the trials that are designed are important to them and reflect their needs, their goals, and of course, their desires. You can read one of the publications of the 10 in the Expert Reviews in Hematology journal. And this was a publication that was authored by our lived experience experts. So the title of the paper you can see here, Lived Experience Experts, a name created by us for us. And the QR code is there. You can download a copy of this paper to read it. And I think it's important to recognize that this provides a template or a blueprint of how other fields can adopt what we've done in the inherited bleeding disorders community and be able to empower lived experience experts to truly be part of the research enterprise from start to finish, not just as participants, but as true partners in the enterprise. So the research continuum is from being aware of research, being a user or a participant in research, to being a leader. And several lived experience experts have now emerged in our inherited bleeding disorders community as research leaders, creating and designing research programs and protocols, getting funding for the research at a not only a nominal, but at a substantial scale, and then be able to provide the knowledge and expertise in terms of publications and presentations of their research. So we've got a number of these individuals who really can serve as the outstanding lived experience experts and leaders in our research enterprise. So again, there are multiple opportunities for lived experience experts to participate. We believe that they can participate in focus groups as research ambassadors, getting the word out, as on research committees and advisory panels, but most importantly, as co-principal investigators throughout the entire research enterprise. If you're interested in participating in future research initiatives as a lived experience expert in the inherited bleeding disorders community, no research or scientific experience is required. We really want to take individuals who live with inherited blood disorders and train them, help them become the most capable and the most powerful people in the research ecosystem. So again, the QR code can get you more information about what you can do to become part of this movement. And our goal is, our first project was in the inherited bleeding disorders community. But we would like to be able to use this platform and what we've learned over the last 4 years to help other communities in the inherited blood disorder space to emulate what we've been able to do and enhance research so that it's truly impactful for people who are living with these disorders. So if you'd like to join us, please do so. So with that, I'll end and thank you for your attention.
Thank you so much, Dr. Valentino. That was amazing. It got me really excited. And I'm already I QR code all those links that you sent. Really want to see how this can help other disorders. So thank you. I'm going to share my screen.
Thank you.
And thank you all that are joining us today. Again, if you would like to put where you're joining from in the chat as we prepare for our discussion upcoming. My topic will focus on advocacy and health policy, the journey that sickle cell disease and thalassemia have taken. Here are my disclosures. None of them are relevant for this presentation, and they've all been completed. But I also wanted to disclose that although I'm a pediatric hematologist, and I've been taking care of children with both sickle cell disease and thalassemia, I do live in Texas in the United States, and I will share some of the successes of our friends in Canada. But if you feel like anything is being misrepresented, it's all from my end. And I thank those that were generous with their time to educate me, but I'm looking forward to the discussion if there's anything I left out. So we're going to talk about a lot of things that solidify what has already been presented by Dr. Rowley and Dr. Valentino, understanding that importance of the non-medical drivers of health and how that impacts sickle cell and thalassemia, as well as the national and state policy initiatives that have helped these two diseases in their quest for better health outcomes. And we will touch on this very briefly, but just in different parts of the presentation, I'll mention some of the evidence-based care guidelines for sickle cell disease and thalassemia, or at least reference where to get them. I don't need to talk about sickle cell. I know we had an introduction today, but just to emphasize that burden, a disease that has one mutation leading to so much pain and destruction. And sadly, a component of that pain and suffering also includes early mortality, as Dr. Rowley eloquently went over. And so just to keep that in mind, we pat ourselves on the back that, at least in the United States, there's some things, and in other developed countries, we have done some preventive measures for sickle cell disease that has improved that lifespan in children, as you can see here. However, this is what we have. This is it. We say early diagnosis is key with newborn screening. We also say early start of preventive medicines, both from the infection side and the organ damage side, is important. We discuss immunizations. We educate caregivers on how to recognize symptoms of acute illness. We've even figured out how to screen for those at risk for stroke. And these have been very much amazing findings and successes that we should be proud of, except there remains a huge gap. And this is something we should be ashamed of. This article came out in 2021, and it mentioned, the title tells you everything. These sisters with sickle cell had devastating and keyword preventable strokes. This should not have happened. But our own, in the United States, our own Centers for Medicare and Medicaid released a report that same year that noted that even though we recommend care for sickle cell, people are not actually getting the care that we're recommending. For instance, they found that of the people that receive insurance from Medicare and Medicaid services, only 36% of eligible children had the stroke risk screen. So you can imagine there's more stories similar to these sisters in our country. And then when you think about the life-saving interventions that were mentioned, hydroxyurea and penicillin and vaccines, there was a big gap on who was getting those therapies and preventive options. And this has also been supported in the scientific literature, study upon study that discusses this question of equity and quality when it comes to sickle cell disease, and why is there a gap between what is recommended and implementing what is recommended. I think a lot of us here today know the reason why. Sickle cell is a unique disease in that in the United States and in Canada, it is a rare disease. And so in that standpoint, when we talk about our other brother and sister disorders, there's a lot of shared experiences being rare, but it's not rare when you look at it from a worldwide setting. It's a global burden. And that global burden is basically a huge call to action for all of us to do more, because no matter where you reside in the world with sickle cell disease, you are facing some kind of invisibility and disparity. There's lots of stigma, no matter, again, where you reside. And the concept of being neglected by the healthcare system is there. And then it's a scientific double-edged sword. I love the presentation that Dr. Valentino gave, because scientists, clinicians were always fascinated by sickle cell disease and about blood disorders in general, but yet the caveat is that we have not been able to use that fascination to move us forward very far at times. And so what is lacking is quality care and funding, and this is where advocacy becomes important. So how do you solve a problem like sickle cell? Well, the main point is that we have to redefine the problem. You know, if you only look at it as a blood disorder that needs to be fixed in a scientific way, and if you only look at it as a research problem, you will not be able to hit on all the issues. You have to see it as this comprehensive problem that impacts society. And so when you emphasize that societal problem with sickle cell, you start to address some of those problems. And so how has that happened in the United States? Well, Dr. Rowley already gave a beautiful timeline, and she started with 1910, and then I had to modify the timeline, right? We have to jump ahead to the 1970s. I'm not going to go over the acts that she discussed, but suffice to say that because of advocacy from people like Dr. Rowley's, the Dr. Rowley's of the 1970s, and people that were lived experience experts, as Dr. Valentino mentioned, we were able to get 3 different acts passed over time, and they're working on another one as well. That first act did first see the question as, oh, we just need to improve research. And they only focused on research. Later on, the other acts realized the importance of focusing on access to care and really understanding the population and the disparities that are faced by the population. Other shout outs on this timeline include newborn screening and its long journey. The first state in our country got approved in 1975 for statewide sickle cell screening. However, it wasn't until 2006 that all 50 states had screening for babies for sickle cell. And then we are happy that there's drugs for sickle cell, but it's very, very sparse. And so for the 2020s and beyond, the TBD, or the to be determined, it's up to us. It's up to people like our teams here with GANSID and all of you in the work that you do. We can continue to improve this story. And so I want to give you just a brief example from my state, Texas. we also were trying to figure out how do we redefine the problem of sickle cell. And since 2016, there have now been 3 committees dedicated to sickle cell disease. And the 2 that are still active are doing the work in these target areas. And I won't go into detail, but one example I'll show you is we don't know how many people in our state have sickle cell. We have estimated numbers, but we decided to start figuring that out. And this particular map shows how many emergency room or urgent care visits were made by people with a diagnosis of sickle cell disease. And you can see that there's a lot of, the darker the blue, the more people are seeking care. Well, I went and took another map, the map that's the population density map for Texas. And so the darker the color, pink and red, that's how many people live. But look at the dark blue areas that do not overlap with a clinic that serves sickle cell disease. So our state is one of the largest in this country, and we have a lot of room for improvement in this area, but we wouldn't have maybe appreciated it, and we wouldn't be able to get our leaders to appreciate it if we don't show them the power with data. And so this is where that interplay of health policy and smart advocacy, like strategic advocacy, plays a role. So now let's talk about Canada. So please, again, Canadians, please forgive me if I misspeak. I want to thank Mrs. Tunji Ajayi for her generous mentorship in this area, and I'm sure I'm going to leave somebody out, but yes. So how did Canada move and change the name of the game? Well, let's start with the national level. First, newborn screening. Now, I already told you United States sad story of 1975 to 2006. That's quite a lot of decades. So what happened in the Canada side? Well, kudos to Mrs. Tunji Ajayi. While she was with the Sickle Cell Disease Association of Canada, they started doing that advocacy work, getting people to pay attention. And that has now led to most of the provinces having universal sickle cell screening. And I have to show the timeline because, and this is from information that I had looked up. So again, I apologize if anything is inaccurate, but in the late 80s, when Quebec was like, hey, let's try to test for sickle cell, they were not able to get it universal in their province officially until 2016. Ontario, you can see they started in the late 80s as well, and they felt like they could use the claim of universal by the time it was 2006. I think by the time Ontario and Quebec were like, hey, brother, this is my version of the story, brother, sister provinces, we could do better. And also, of course, the advocacy from the community groups, it slowly pushed the other provinces to get on board. And I know, as you all probably have seen, newborn screening is not an easy feat, but adding sickle cell to a known newborn screening program is something that should be definitely considered. And so I'm glad that this has now become a priority. And you can see that most of the progress has been within this last decade, where you got the majority of the provinces. And so I'm not going to name names, but I put the map of Canada so you can see who is not on the list yet and who we need to write letters to. And so another thing that Dr. Rowley mentioned that I won't emphasize again is that in Canada, the National Sickle Cell Awareness Day became official in 2017. And I think that's just beautiful, that recognition. But what about in a provincial sense? So I use the example of Texas, which is one of our 50 states. And we're going to use the story of Ontario in this instance. We already talked about Ontario's successes with newborn screening. Well, another thing that they've been doing, and if you heard the talk today given by Mr. Elbard in the morning, Elbard, yes, you would have seen a little bit of this. In fact, he dived into it very well. But there's this cross-disease advocacy that came to play when talking about hematology comprehensive care clinics. And so the Ontario Hemoglobinopathy Patient Association, as well as the Sickle Cell Awareness Group of Ontario, worked with the Thalassemia Foundation of Canada, and they were able to get this funding that Dr. Rowley had mentioned. And what's more exciting is that they're now going to be up to 10, which I'm very excited about. And we know it's going to help that many more patients. And so how many patients do you actually have? Well, they wanted to answer that question too. I told you I don't know the number in Texas. Well, Ontario's trying to figure it out, and they actually worked together with the Sickle Cell Awareness Group of Ontario, and they were able to apply for government resources to help understand this problem and count the system. And I'll show you a little bit of that in the next slide. And then another publication that I want people to hear about is the Quality Standards for Sickle Cell Disease. Now, this was launched in partnership with the Black Health Summit Table of Ontario Health, and it allowed the Ministry of Health to work together to have stakeholders come together, including those impacted by sickle cell disease, to write quality standards. I had the privilege of reading this, and it was beautiful. So I encourage you all to go and look at that. And then Ontario also acknowledges June 19th, in addition to what the entire Canada does. So this is a glimpse. I mentioned that number affected. This is a glimpse of this report. Again, the power of data. So yes, we expect the Toronto area to have a lot more sickle cell, but every single dot on this map is important because they represent at least 2 people that have sickle cell disease. And so we need to make sure that they're getting the right care. And then I also love the fact that they were able to get enough data to show their distribution by gender over the past 10 years, over a 10-year span. So again, data starts conversations and help us know how to prioritize those high need areas. Now let's talk about thalassemia. I think I mentioned this in my introduction. I have sickle cell disease. I come from Nigeria, which has a lot of sickle cell disease. So I eat, sleep, and breathe sickle cell disease. But I also love our sister disease, thalassemia, which also impacts several individuals from sub-Saharan Africa, as well as around the world. And I will claim that I am not as much as a thalassemia expert as I am as a sickle cell expert. So again, to those that are impacted by thalassemia, forgive me if I misspeak at any point in time, but look at the burden. So this is a story not about a misshapen cell or a problem with hemoglobin molecules. It's a problem of not having the right balance. And depending on what your genes, what you inherited, that balance can lead to so many different things. And so clinically, what that leads to is a spectrum of people who don't look like they're sick, but maybe occasionally might need support, to people who depend on lifelong transfusions unless they're able to get a curative or transformative option. And so when you splice back all the things that are going on with thalassemia, just like sickle cell, the one mutation leads to so much damage throughout the body. And we're not going to go into detail, but just appreciating that and why this rare disorder needs advocacy and the appropriate care for each and every one of these organ systems. So what about progress for thalassemia? Well, I'll start with the United States. The Cooley's Anemia Foundation was founded in 1954 by a parent, Mr. Frank Ficara, and other parents. They were like, you know what? Our children need our support and they need better health care. So first it started simply with blood drives, neighborhood blood drives, but as they came together and organized, they focused on educating their society. And then as they grew in confidence, they were able to advocate at very high levels. Fast forward, and they are now leading in funding medical research fellowships in the hundreds of $1,000s level. It's very impressive. I want to acknowledge the national president, Mr. Ralph Colasanti, as well as the team that I have been able to interact with, Mr. Butler, as well as Mr. Hemraj. And then one of the exciting things that I get to learn more about thalassemia, as I mentioned, I'm seeking more knowledge, is I often go to their educational workshops that they do with the Centers for Disease Control and Prevention. So now let's talk about Canada. And so I am happy that we have a few members of the Thalassemia Foundation Canada here. So again, you can add to this during our discussion. Founded in 1982 by Ms. Angela Polsinelli, and she's a parent. She was a parent as well of, and she partnered, with other parents and patients and together began the beginnings, the foundational work of what would eventually become the Thalassemia Foundation Canada. They started as a support group, parents and families seeking support from others that had shared experiences. That led them to also realize that, hey, people are not educated about this disease at all. Let's do something about that. And then similar to Cooley's Anemia Foundation, once they had enough experience and confidence, I will say, it led them into this advocacy space. And now they fund research grants also in the $100,000 range, Canadian dollars, I'm assuming. But it's very impressive work. I want to acknowledge that the president is actually here with us today, Ms. Bessie Calabria. Hope I pronounced your name right. And I also want to acknowledge the immediate past president who gave such a beautiful talk this morning, Mr. Elbard. Another fact about the Thalassemia Foundation of Canada is that they do interact with the Thalassemia International Federation and are part of that membership. So now we're going to end and still give us time to talk a little bit. But everything that we discussed today basically shows that the disorders that we care about at GANSID are impacted not just by the medical system, but by so many other factors that we call social determinants of health, and some people phrase as non-medical drivers of health. We need to find ways to improve each of these areas. And you heard today from Dr. Rowley, Dr. Valentino, and a little from myself about how people have been trying to approach these gaps. I'm going to skip over these other slides. I just want you to know that for both thalassemia and sickle cell, there are conferences. There is now way more education. Nobody should say, oh, I don't know what thalassemia is. I don't know what sickle cell is anymore. And so I'm just going to flash these dates on the screen, and you can either screenshot if you want to know more information about these initiatives. These are some of the upcoming meetings related to sickle cell, including the Sickle Cell Awareness Group of Ontario. They're having their summit in a couple of weeks. And then I'm excited about this in 2025. I hope I see y'all there. And some other collaborative working things. And then my very last slide is just give another shout out. If you are here today, you don't know enough about sickle cell or thalassemia, you want to learn more, I refer you to these excellent podcasts on both, some of them focus on sickle cell disease and some of them focus on thalassemia. But you can learn a lot, and I've learned a lot actually from listening to them myself. So thank you again, and we'll now open it up for questions for all three of panelists, as well as any other thoughts people would like to share. Sharing.
A couple of things on my mind, but I would like to have the attendees ask the questions first, if there's any.
And I'm going to scroll to make sure we didn't miss anything. Lots of comments and praise about the poems and the things that you shared, Dr. Rowley. And Ms. Calabria, welcome again. And Dr. Valentino has shared some resources. All right. So yes, any questions? And why don't you go ahead and get started, Mr. Elbard, while people are writing their questions.
Well, some of the thoughts that came to my mind, well, this is something that's always been on my mind, is we do have a lot of opportunities and challenges at the same time. I mean, all three diseases we have presented today, and I'm sure some of the other inherited blood disorders, we have a new curative therapies that are very expensive. And, you know, I'm talking about gene editing and gene therapy. And they're well available in North America, definitely in the US for thalassemia. How can we, as GANSID, advocate for access to these new therapies? I know that's a big question, and it opens all sorts of discussion points. So that's one. The other thing is we're lucky in the sense we have ASH as the biggest hematology association in the world. I think it's larger than EHA, and how can we influence their decisions, their work, and try to attract more interest, raise more awareness, maybe more funding? There's a lot of money that goes into research. How can we work on getting more funding into these diseases? I know and I choose to give a lot of money for research. They did give for thalassemia a while back, but that's many years ago. And then it stopped. How can we tap on these things? I mean, these are opportunities we have. They're challenging, but they're put us in a good place to start as groups in North America.
Yeah, and yes, Dr. Rowley, please go ahead.
So I'm going to answer that question by stating this. I believe, as an adult person with sickle cell disease as well, that monies need to go to the persons who are currently living with the disease. And first and foremost, as we've seen, the mortality rate is higher among those with sickle cell disease than in their respective countries, right? That needs to be changed. So I know that we're looking prospectively to therapies, but I also am responsible for at least a couple of thousand here in our state. And we need to make sure that the EDs, other providers, are well aware of how to treat. We're still talking about how to manage. This should be something that we don't even talk about anymore, but we're still talking about how to manage a disease that we're mighty aware of. And so we need to know how to manage so that we can actually decrease mortality. That's first and foremost. Second, in terms of transition, the highest number of persons that we tend to lose are in their 20s because of that transition age. So I have all the respect with respect to research, I do, but we have people who are living right now, and too many times we've lost them. For instance, Diamond Ray, Natasha, Bobby, and the list goes on, all because someone was not aware of what they actually needed to do. And that particular complication could have been, it didn't have to occur the way that it actually did. It was preventable. So I would just like to always make sure that when we have the lens of research, that we also go back to who's here now and how we can get our persons living quality of life right now and not have to fear. People fear for their life, which is why they actually stay at home and manage their disease at home. And then they wait too late sometimes, because then they have to figure out that traumatic experience of going into the ER. Recently, I was advocating for someone. You guys are not going to believe this. This is with Advocacy. This is with Advocacy. Do you know that it took 19 and a half hours for that person to get her first pain medication? That's absolutely ludicrous. 19 and a half hours. She didn't present with anything more than vaso-occlusive crises. Why did that happen? The good thing is I'm glad that we were there, and she was able, it took a minute, but she was able finally to get back to her state, because she was out of state, and she called us for help. So I want to just kind of always put that lens of what are we doing for our warriors here right now? Thank you.
I agree with you.
Let me comment on Dr. Rowley's comment, because I think it's really important. What you said is exactly what we are trying to develop, or in one way combat. And that's, research is often done for the benefit of the researcher in the past. And it's for academic progress and advancement, not necessarily for the person living with the disease. And we have tried to turn the research enterprise sort of on its head by focusing the research on what the lived experience experts, you, say is most important. So all of the research priorities are true that we have been able to develop through the research state of the science and now in the National Research Blueprint are grounded in exactly what you said. It's what's important to people that are living with the disease today. And those are where the research priorities are coming. And again, I think what we've done is for inherited bleeding disorders, whether that's hemophilia or von Willebrand disease or platelet disorders, or some of the ultra rare bleeding disorders. But this can be used as a template for others, but it requires cooperation and collaboration and community coming together and not having all of these disparate factions sort of competing against each other.
So agree.
Yeah, I agree. I was trying to type my answer, but I'm just, I didn't type fast enough. I think thalassemia and sickle cell disease can learn from hemophilia, because some of what you were saying, Mr. Elbart, is very important. Now there are multiple hemophilia treatment centers. They're qualified, they're certified. We know that you're going to get quality care. And so access to them involves you identifying the right center and getting yourself there, and there's support for that. Thalassemia is so rare and so variable, but we know that our most severely impacted, the ones that need the chronic transfusions lifelong, they almost always have access to care because of that need for transfusions. And we're speaking about North America. We know that this is not the case in other countries. And this is where sickle cell ends up being back to that scientific double-edged sword. The science is there now. Oh, gene therapy for both. But at least for thalassemia, I can find the patient. I can, okay, well, I can start with my severely impacted thalassemia patients and try to get them into the gene therapy system. And, you know, there's still barriers for that, back to your point about the need for funding. Those heavy price tags, there's a waiting list because, again, of those price tags. So I'm not saying that thalassemia and hemophilia have it all together, but that first question of, do you have access to care from a reputable center that can take care of your disease? That is significantly lacking for sickle cell disease, just to emphasize those points. But I do like what you're saying about pushing people to be better and do better. So one of the fallacies of hematology oncology is, at least for pediatrics, we partner one of the most highest resource disease with some of the most lowest resource disease, right? Front and center. And that's just hard to watch, right? For decades and decades. So finally, groups like ASH and NIH were like, you know what? We can't wait for some magical genie in the sky or celebrity in the sky to drop millions of dollars for sickle cell. We need to do better. We know better. We need to do better. And so I think we need to continue to speak strongly. A name like GANSID that has all of us working together saying, hey, we're here. We're not going to keep quiet. I think that continues to. So one thing that I like to say when I show those timelines, you see these kind of winds of change, like a bump and then a dip. I don't think we're going to dip anymore. I really don't. I think this is our time to stay soaring. And it takes people like yourself and, you know, like everybody here today. But yeah, I refuse. We're not going to dip. we must continue to demand.
And I agree, and I hear you, because a patient at my age, I don't qualify for the gene therapy, so I know how it is, that getting
Tell
the
me
treatment
about that.
is the important part. And I do appreciate the fact that sickle cell has a huge struggle with getting the treatments at the hospital. I'm, you know, we need to advocate at many different levels and at many different fronts. We have to set priorities, I guess, for North America and see what we can achieve within the capacity that we have as GANSID or as, you know, individuals as well. So this is good. I mean, that's what we wanted to have this discussion for. We certainly learn a lot from hemophilia. I mean, in Canada here, we also, the Thalassemia Foundation and myself personally has been part of the Network for Rare Blood Disorders, which is led by the hemophilia when it started, and it includes other rare blood disorders such as aplastic anemia and you know, hereditary angioedema and many others like Fanconi and, you know, all these.
I put another resource in the chat there. So we had published a manuscript in 2021 around comprehensive integrated care for people living with hemophilia in the Journal of Blood Medicine. We actually were forced to revise the manuscript from using this as a template for blood disorders because the reviewers felt that there wasn't sufficient information available to make the leap from hemophilia to other blood disorders and comprehensive integrated care. So we weren't able to use that. We had to change the title, et cetera, and focus the manuscript more on hemophilia and other bleeding disorders. But again, I think this is a template. And this article has all of the pieces that other communities could take to develop that comprehensive integrated care and the network that's necessary to support that kind of integrated care across the spectrum of diseases.
Thank you for sharing that link. Completely, I think hemophilia, you'll hear for sickle cell, you'll often hear us be compared to cystic fibrosis, but I feel like hemophilia has definitely had the recipe that allows us to model even more astutely, because again, same types of doctors caring for the patients. And so we can certainly learn from those models. And what both of you, or all three of you said actually struck me. Since I don't see anything in the chat, I wanted to throw out these two themes I'm hearing. There's a theme of the majority of people who are lacking access to care. And in this particular bucket, sickle cell is the poster child. However, there's also this component of outliers because the resources never seem to be enough. So we have the huge problem of those that don't get access to care. And then you have a subset of the community that were the outliers. We're too old for some of these therapies, so they tell us, or the side effects might be an issue, or even that big population in thalassemia intermedia, where we're hoping we can do better.
Yeah, not only that, no, but Dr. Rowley actually hit on a very important point, which is a lot of the vulnerable patients are those that are through the transition ages, which is from late teens to early 20s. And that's something where we need to try and target, because that's when you need the care. And that's a critical point in the life of the patient. So I couldn't agree more on that.
So I'm hearing two big, so transition and general access. Dr. Ivy, I don't know if you have anything to add, or those that are listening. Okay, thank you for the chat post as well. Welcome. Thank you so much for joining from the Obi Ogbonia Sickle Cell Foundation. Nice to meet you. And for those that are trying to still work the chat, to Mr. Elbard's point, these are conversations because GANSID actually wants to take this information. We recorded this session. We want to take this information and prioritize and say, hey, this is where we should put our efforts. You saw models of different ways to do things, but which one makes sense for GANSID to take the bull by the horns? Go ahead, Dr. Ivy.
Oh, yeah. Can you hear me?
Yes.
I was just going to say that, I think the fortunate thing is that we do have a lot of models that we can look at and pull from. My personal opinion, and this is just my opinion, is that, you are going to have to consider place where you're trying to initiate these initiatives. Some areas may be more receptive to certain strategies, whereas in other locations, we may have to take different approaches. When you look at particularly North America, there are high resource areas that may have, more to address sickle cell needs. And when you think about like California, New York, areas like that. But even in those states, you may have some regions of those states that are lacking in resources. So I think earlier you showed Texas, for example, and you can see where in certain parts of Texas, yes, there are centers, there are resources for sickle cell patients to get their needs. But if we were to then make the assumption that, oh, well, Texas is covered, we've made a mistake because there are large regions of the area that are not covered. So I think as we begin to roll out these strategies to improve care, we look at the area that we're trying to target and what are the best strategies for that specific area, and they may be different. What I do and if I may use Ontario as an example, what I do in Toronto may be a lot different than what I do in like Stratford, Ontario, as an example, because it's a different region. I do think, we can always though look at lessons learned. We're fortunate here to have someone from the hemophilia a community with us, someone from the thalassemia community with us. We all struggle with the same challenges. They may just be different. And these are rare diseases. And so you look at the number of individuals it impacts. How do we, as a collaboration, bring our voices together so that we're speaking the same, about the obstacles in a similar way, so that they can be adequately addressed. One thing I do want to say is that we are at a turning point, I believe. Gene therapy and gene editing may really change the game. It may be that cure for hemophilia, for thalassemia, and for sickle cell disease. So I think we have to come together as one community, as a inherited blood disorders community, and say, how do we address the future with gene therapy for all individuals that suffer from inherited blood disorders?
Yeah, there was a question that was raised earlier about the ability to bring these innovative therapies into the developing world, and how can this be paid for? How is access going to be achieved? I think this is a really important question. How we do this in an ethical way really has not been discussed and debated, and it really deserves a national and international forum to be able to talk about how these expensive therapies are really allocated into the developing world in low middle income countries. There's one example. The St. Jude Children's Research Hospital is developing a program to bring gene therapy in one small area, hemophilia B, into low-income countries. And the model that they're developing is one that potentially could be used in other bleeding disorders, but more importantly, in other blood disorders. And I think, having innovative ways to think about how we do this is critically important. And St. Jude, holds a unique position because of their funding model. But there's ways that this could be done, and unfortunately, the innovation right now is being held in for-profit companies that have fiduciary responsibility to their shareholders, and they're not going to give it away, unfortunately, and they're not going to give it away to low middle income countries. But I think there needs to be some discussion and debate about how we, as a blood disorders community, sort of force the hand of industry to be able to deploy these life-saving therapies to people who truly need them. In the case of hemophilia, we know that 75 to 80% of people living with hemophilia don't have access to treatment because they live in low middle income countries. So it's not, the situation is not great for hemophilia, where you think it's, at the top of the mountain, so to speak. So there's still a lot of work to be done in all of these areas.
Well put, Dr. Valentino and Dr. Ivy. Those are all insightful comments. Because of our time, this is so wonderful conversation, but we do respect the fact that you may have other points to be at, and we know some of you are waking up early to join some of our brothers and sisters with the other workshops. I'll try my best to make the one for Africa. And so please, we're going to share a poll for participants. Please fill out the poll for us. It helps us know how to improve as we're already anticipating next year. So We would love to hear your feedback. And again, thank you so much. This was an honor to participate.
Thank you. Thanks, everyone.
Yes, thank you.
And thank you.
And after you fill out the poll, we'll leave this open for a little bit. You can sign off. If you're still seeing that poll in front of you, please fill it out for us. It helps us give great feedback and let us know how we can improve for our next session, or also tell us what you thought about the conversation topics, if there's anything else you feel was left out. I still see a few of you, and so maybe you're still working on it. We'll leave it up for a few more moments. Thank you for your comments. Thank you for joining us.